Good evening, everyone. Welcome to the masterclass session, which we usually bring about every Tuesday, where we discuss about topics for an exam-going students. So for this week, we are going to talk about a case on pulmonary embolism. And to moderate this class, we have senior experts, Dr. Binila Chakku Madam, who is head of the Department Critical Care from CMC Vellore. And we have Dr. Saurabh Taneja sir, who is a senior consultant, Sir Gangaram Hospital. So both of them will be moderating this session. Welcome, madam, and welcome, sir. And we have students, Dr. Sai Kishan and Dr. Shiva, who are students of Yashoda Secunderabad Hospital, who will be presenting the case. Over to you, Dr. Sai Kishan and Dr. Shiva.
Good evening, everyone. I am myself, Dr. Sai Kishan.
Good evening, sir. Good evening, ma'am. Myself, Dr. Shiva, Additional Resident, sir.
Good evening. All the best to you.
Thank you. So, a 60-year male patient, previously he was admitted in urology ward, presented with a shortness of breath, MMRC grade 4, since 20 minutes. So, a med call was announced for the same complaint. So, we went there to assess the patient to see what is his clinical status and condition. So, patient was apparently normal 20 minutes back. So, present illness started as shortness of breath while going to restroom, sudden in onset, progressive, which progressed from MMRC grade 3 to grade 4 within 20 minutes. He was brought back from the restroom and connected to oxygen with a face mask. In the meantime, team has announced a med call. On arrival, patient was unresponsive, BP is not recordable, he is in a bradycardia, followed by pulseless electrical activity. So, as early as possible, CPR was started and continued as per ACLS protocol. So, during CPR, patient got intubated. RASC achieved after 4 cycles of CPR, sir. Immediately, patient shifted to ICU for post-cardiac arrest management.
I just have one question for you in the previous slide. Just the basics of MMRC. What is MMRC actually, and when is it used? When is it supposed to be used? Or is there a better grading?
MMRC is Modified Medical Research Council grading, madam, used mostly in pulmonary conditions. So we can use NIHA classifications, madam, but it is more of a cardiac.
Who does the scoring actually for the MMRC actually? Is it a subjective, is it a patient-based thing, or is it a clinician-based?
Subjective.
Yes, so generally it tends to be more subjective when you're giving the patient the sheet to kind of fill and say, okay, fine, what category do you fit in with? In a patient who is in the hospital and has an acute onset breathlessness, in this situation, it's difficult to say, even though the NYHA is more typical of heart failure, that may be a little more acceptable grading of respiratory distress in this situation is one thing which I felt.
Okay.
Then, sorry, Dr. Saurabh, you want to say something?
We definitely agree to this. This is not the ideal grading system to be done for respiratory.
So when you have a patient like this, I know the scenario which has been given and the case which we've been told to discuss is about pulmonary thromboembolism, but what are the differential diagnoses that you would consider in a patient in this situation? In a similar situation like this, suddenly collapses, PE arrest, what are the differential diagnoses you would consider?
Acute coronary syndrome, ma'am. MI, acute MI. So, acute CVA, pulmonary thromboembolism, aortic dissections, and
Now let's think about it in this situation. So you're saying acute coronary syndrome, okay? Acute CVA also. CVA causing the breathlessness or?
more of
patient who
unresponsive
breathlessness to cardiac arrest. So think about differentials which can lead from breathlessness to cardiac arrest.
Yes. So what else could, like, sometimes, okay, so acute coronary syndrome, all right. Pulmonary thromboembolism is another thing. What else?
tension.
In this situation. Okay, tension pneumo, maybe, may not be. We don't really have anything else.
Aortic dissection.
Okay, how often have you seen that in our something more common? Look at it in this patient. I know we haven't gone through the rest of the history, but then in this patient, anything else? It's a post-op patient, right?
Heart
It's a post-op.
failure. Heart
Sorry?
failure. I mean, heart failure or aortic stenosis can.
But he's had a surgery. I presume he doesn't have that condition. Could
Okay.
he be having, I mean, sometimes, patients, you have this respiratory distress, which may be just a feature of, may not be respiratory at all, but maybe just dyspnea in relation to metabolic acidosis, whether he's had a bleed, a major bleed. I'm just trying to think like hemorrhage, okay, leading on to shock, whether something like that. So in the list of differential diagnosis, in addition to acute coronary syndrome, pulmonary thromboembolism, tension pneumothorax, think of this also as
Okay.
hemorrhage, especially given the clinical scenario that the patient is in at this point of time. But can you tell me, based on this slide itself, a few features which makes acute coronary syndrome less likely?
There is no chest
Chest
pain,
pain.
madam.
Mm, anything else?
Tachycardia.
So, I mean, I think one thing which kind of makes it less likely for me, okay, fine, symptomatically, even pulmonary thromboembolism could have chest pain. And MI could also have chest pain. Aortic dissection could also have chest pain. All of them could have that. But typically, having a PE arrest in a patient with an acute coronary syndrome is less likely. That kind of puts pulmonary thromboembolism higher up, even though an RV infarct and posterior infarct can also have this, but it makes it less likely and probably pulmonary thromboembolism higher up on the list. Okay. We can move on to the next slide, unless Dr. Saurabh, you have some
I
questions.
just wanted to highlight that point that since the only history that they gave in the first slide was a post-op surgery,
Yes.
post-op complications definitely take a precedence over other less common things which can happen in this patient. So that is the only history they gave, probably.
I agree.
Yeah, you can continue. We can think about what are the patients that this is a patient who has went into cardiac arrest. So what are the possible causes of cardiac arrest in these patients and how did you manage? So in this slide, actually, the Viva can actually move on to cardiac arrest and post cardiac arrest care, and they can discuss it very much in detail in this slide.
Yes, sir.
Yeah. So you should be familiar with the AHA protocol, the recent guidelines, the recent changes. So
Yes, sir.
how was the CPR done, if I may ask you, in this patient? So this patient presented you with bradycardia and then pulse electrical activity. You said according to AHA protocol. What do you mean by AHA protocol?
Patient should be made lie flat, then start chest compression, sir, at the rate of 100 to 120 per minute. Then 30:2 ratio breath should be given. Then
Is there a
initially we have
specific,
to assess initially we have
is
to
there
assess the pulse.
is there a specific terminology which you call that? It's got a very specific terminology, no? High quality
High quality
cardiopulmonary resuscitation. That
resuscitation.
is the term which we expect from a trainee.
Okay.
And then you can go on to give your description about the depth, the rate, adequate compressions, adequate recoil, minimum interruptions. Okay, that should all come, but the first term should be that. Okay.
AHA has got definite terms, high quality resuscitation, the 4 points, the CAB sequence, the 30:2 ratio. You have to come out with them. There is no option as a trainee, as an examinee, after going 1 or 3 years, you don't tell these things. You have to.
Okay.
So then when do you intubate such a patient during resuscitation? Do you immediately intubate this patient? You said you are intubated resuscitation. So when do you intubate this patient? As soon as the code starts, you intubate these patients or you wait for a while?
Sir, we can give bag and mask, sir, with oxygen. initially.
Have you attended the recent AHA ACLS course, or I mean, just to know the guidelines?
No,
This is
ma'am.
a very important point which Dr. Saurav is trying to say. So earlier, actually, we used to be thinking about, bag mask and weight, but then the focus on the last 2020, and I presume the 2025, once it comes out for training, will be on minimizing interruptions in chest compressions. The focus is minimizing interruptions in chest compressions. Okay.
Okay.
And we're looking at chest compression efficiency and efficacy, and there's a ratio which they look at in terms of chest compressions and how efficacious it is. So airway, getting control of the airway, either with the help of an ET tube or with a supraglottic device, is also is to be done not like immediately, but they actually talk about it, by at least by the second round of starting your compressions, you should have got an airway so that you're not minimizing, you're just doing continuous compressions and minimizing hands off
Okay.
the patient.
There's a
Okay,
terminology
so
called chest compression ratio. So during the
yes.
time that you're doing resuscitation, how much time do you actually doing chest compressions? The percentage is defined and you have to be confirmed with that percentage. And usually in the Western world, there's a person who's actually recording this.
Okay, sir.
Yeah. So you should be familiar with these terminologies when you're actually mentioning any resuscitation according to ACLS protocol.
Okay, sir.
Yeah. You can move ahead. Yeah.
So in past history, he's a known case of benign prostatic hypertrophy. He underwent laser TERT 3 days back. He's on continuous bladder irrigation. He's having chronic kidney disease, who is on medical management with baseline creatinine of 1.8, known hypertensive since 4 years, on cilindipine 10 mg OD. No other significant comorbidities and no significant personal and family histories.
So any complication you think that bladder irrigation can cause in such a patient? Any metabolic complication?
Hypernatremia can occur, sir.
Okay. So can this be a cause of arrest in this patient? Because he was having 3 days back bladder irrigation.
But routine serum electrodes are showing that sodium is in the normal limits only, sir. And previous report showing sodium is 140.
Sodium was fine. Okay.
145.
Fine.
Any other reason why this post-operative status, like in this list of past history, I mean, actually, to me, the BPH and the TERP should not be part of past history, because it's actually very relevant to this case and should have been in the history of presenting complaints, that he's 3
That's
days
3 days
post.
back. Yeah.
Yeah, that it should not be in the past history. But why is the post-op status relevant here?
The prolonged immobilized for the past, one of the risk factors for pulmonary thromboembolism, the patient was immobilized for the past 3 days now. That's the biggest stance is one of the component of which was tried.
So in a post-op patient, when is the risk of pulmonary embolism highest?
Less than 3 days.
Yeah, so in the first 3 days, 3 to 5 days is when the risk is highest. So this patient is day 2 and most likely would not have been on prophylactic anticoagulation. So that is something which should have come up front. Okay. We can move on.
So to summarize the case, 60 years male patient, poster on POD2, who had sudden onset of shortness of breath, had cardiac arrest, post CPR Roscachiv, with
If you had to, like, suppose you were the registrar who was handing over the patient to an ICU registrar, what would be a good way for, or suppose you were the ICU registrar receiving this summary which you have just said, would you want to make it a little more detailed? The summary statement is something which is very important. I think the summary statement should encompass whatever you have discussed. So in general, at least, I mean, I'm not sure how it is for the DNB cases, but like when we get the students to present, we say we would like them to start off by saying this is a 60-year-old man, day 2 post-op TURP, who's come to the ICU post cardiac arrest. It was a pulseless electrical activity cardiac arrest. It was witnessed, right?
Yes,
Yes.
And the time to return of spontaneous circulation was 8 minutes. So that in one way, and he's come to you post resuscitation for post resuscitation care. That's why he's come to the ICU. So in one summary statement, you've got all the key factors, you've got the type of arrest, you've got the time to ROSC, all very clearly. So just that summary statement should be made a little more fine. I mean, Dr. Saurabh, you've been a DNB examiner. I mean, whether you have any ways in which this
ma'am,
can be
as any
fine-tuned.
patient who comes to us post-arrest, witness cardiac arrest, unwitnessed, the initial rhythm, the time of ROSC achievement, what was the rhythm, they are all very essential components and have to be there. There is no way you can miss it.
Okay, sir.
Any patient, because see, whatever the case is, this is a patient who presents to you with a post-cardiac arrest care.
Yes, sir.
Pulmonary embolism, whatever you are diagnosing later on. Okay, this could be any cause.
Yes, sir.
You have to mention these things. Because for the course of events of this patient, these are essential. And you
Okay.
should also mention the vitals here of the patient. When you're presenting and sending this patient to the critical care unit, you should mention the vitals of the patient, whether he's on vasopressors or not, what is the temperature status of the patient. They all have to be mentioned when you're giving a over to the other person.
Okay, sir.
Yeah. And you mentioned differentials, we've discussed them. Yeah, you can start with physical examination. Yeah. Next slide.
On general physical examination, patient was unresponsive.
Why is it important to tell that he's unresponsive here? What is the significance of the patient being unresponsive in a post-cardiac arrest situation?
Hypoxic ischemic encephalopathy, one of the possibilities.
That you diagnose later on. It takes time for the assessment of patient whether he's in HIE or not. Any other thing? So neurological status, if the patient is not responding, you can think about providing targeted temperature management to these patients. Yeah.
Okay, sir.
Okay, go on with the vitals.
Okay. Regarding vitals, heart rate is 120 beats per minute. And regarding BP, it is 80 by 40 mm of Hg with 10 ml of noradrenaline support. And saturation, it is 84% and mechanical ventilation with the FiO2 of 100% with PEEP 8 and tidal volume of 380 ml. Respiratory rate kept at 24 ml per minute on ventilator, and he is febrile. Temperature is 98 degree Fahrenheit.
Sorry, I didn't get that. Just go back again. So you said that heart rate is 126.
Yeah.
Anything more you want to specify? Yes. I mean, I keep on saying, like it's very easy to look at a monitor and say what it says, but then it's for us to kind of say relevant points to this patient.
Sinus
Anything
tachycardia.
else? Okay. So Sayed,
Regular, yeah.
Rate rhythm.
Regularity of the pulse.
that has to come in. Okay. Then if I mean, 10 ml of noradrenaline in my center will mean differently to some other Dr. Saurabh's center. So there's a very, you have to be more specific in the way in which you say how much noradrenaline. How do you define the dose of noradrenaline? Usually it's in mics per kg per minute, no? You
Yes.
have to actually give us that number rather than saying 10 ml because I don't know how much 10 ml is.
Everybody dilutes it differently. Every center, has a different kind of dilution, 1 ampule, 2 ampule, the ampule strength. So
Yes.
Okay, sir.
universally acceptable unit should be used.
Okay, sir.
Okay.
And when you go for your exam, you will not know what it is. You need to ask the nurses how many mics this is,
Okay.
whichever center you go to, and then you have to accordingly calculate and say how many mics per kilogram per minute is this. Okay.
Okay.
And even this, I mean, I was not very happy when you just said on mechanical ventilation with FiO2. And be always good to say which mode.
Mode.
Yeah. Okay. So,
Assist 1 to
and
1.
I got confused. I thought the AF meant atrial fibrillation. This finally you said afebrile. This is afebrile or
Afebrile.
okay.
Use as less as abbreviations as possible when you're presenting a case.
Okay.
Okay, sir.
Okay.
Yeah, as less as possible.
Okay.
And also, it is good for this must have been was this a NIBP or was this an invasive blood pressure monitoring reading?
Is NIBP only, ma'am, non-invasive BP.
This was a non-invasive.
Yes.
So those points also have to be mentioned. Okay.
Okay.
So this is when the patient came to ICU. That's what you're saying right now.
Yes,
Okay.
ma'am.
Coming to systemic examination, on respiratory system examination, patient having bilateral equal air entry and no added sounds. Regarding cardiovascular system examination, both S1 and S2 heard and loud P2. And regarding central nervous system examination, GC is E1 and VTM1. Peoples are 3.5 mm, sluggishly reacting to light. Upper abdomen examination, the abdomen is soft, no organomegaly.
So what does this tell you actually? What from your general examination and your systemic examination? I would have liked in your general examination also, maybe if you told me anything else you would like to say when you so you're trying to figure out, like how is there shock or not? Is shock defined as a number or is shock defined by how is shock defined?
Perfusions.
Perfect.
Define an organ perfusion.
Organ perfusion. Okay, so some markers, I know the patient just come to ICU and this is you're presenting it at this. Okay, maybe capillary refill time may not be reliable, but good to mention it.
Yes.
Okay, or at least mention how the peripheries were, whether they were cold and clammy. And the other thing is, based on whatever you've presented, what type of shock? Because I mean, when you don't present the peripheries, I can't really figure out what type of shock this is. So, like, what type of shock does this point towards? So, include peripheral examination in peripheries and capillary refill in your general examination also.
Okay.
So, what type of shock does the patient have?
Obstructive shock.
Why are you saying it's obstructive shock?
Here, patient having both regarding blood pressure and patient having it is not recorded. So even though we are giving vasopressor support, also patient not improving. Even fluids resuscitation.
Tell me the most important point first, because just because shock does not respond to inotropes does not make it obstructive shock.
Not fluid response.
Why did you say obstructive? It's correct, but I just want to know why are you saying obstructive?
So the main pathology here is there is a pulmonary pulmonary flow obstruction will be there, sir. It is there, ma'am. There's decreased LV filling is there. It leads to decreased cardiac output. So the reason is LV filling defect is there, ma'am. But here.
Okay, I'll maybe just help you with the answer. Okay, so whenever you're asked that question, your response was correct. Okay, the bedside examination points towards a obstructive shock over a cardiogenic shock. And why are you saying that? You've presented very clearly that this patient is hypotensive. Okay, he's got preserved heart sounds. He's got a loud P2. Okay, then you have also mentioned that there is hypox. I mean, like you have mentioned earlier, the saturation is 84 may not be very reliable if he's on RI. But if you've got actual hypoxemia, which is disproportionate to your lung examination, look at your lung findings. Equal air entry, no added sounds. Okay, so you get what I'm trying to say. you are trying to say that the patient, so if you had said the patient had cold peripheries, you can say, okay, fine, this patient has a cold shock, okay? It could be either hypovolemic, cardiogenic, obstructive hypovolemic. There's no history to suggest that. Why I think it is obstructive over cardiogenic is because the patient is hypoxemic with normal lung findings, okay? Normal lung respiratory examination, and there's a loud P2 on my clinical examination. Points more in favor to a obstructive to a cardiogenic shock. I would not have expected normal respiratory examination in a cardiogenic shock. So these are all very, very straightforward questions where you can get marks. And these are the points which you should just learn how to just verbalize it and put it across.
And you're expected to answer these after the end of examination. If you're presenting a case of shock, you have to make diagnosis. Why you think this kind of shock is there and what you can rule out.
Okay.
And at the exit examination, you're expected to answer these.
Okay.
Next slide.
And sorry, just one more point I want to mention. I know this is a case presentation for pulmonary embolism, but just in general, whenever you're making or commenting on neurology like GCS of 2T/15, always mention whether the patient is on sedation or not on sedation. It's, as an examiner, I need to, even if I'm not seeing the patient, I need to understand, okay, the patient has just come post cardiac arrest, he's not on sedation. This is his GCS. Okay. So please make sure that you always present your neurological findings and correlate that with the infusions which are on.
Okay. Regarding labs, before cardiac arrest, patient except the creatinine is 1.8, remaining other lab parameters are within normal limits only, including 2D echo, ECG, and chest X-ray.
Any ABG you have of this patient?
Yes, we did, sir. This is the ABG during ICU CPR, sir. So pH is 7.21, PCOD is 46, PO2 is 39, bicarb is 19, and lactose are 5, electrolytes sodium 142, and potassium is 5, sir. So with these ABG, we are shifted the patient to ICU. So within 5 minutes, patient had cardiac arrest, and within 45 minutes, he got arrested 5 times, sir. So there is a worsening shock, and he was on triple supports. Both
Comment on the ABG. Please comment on the ABG.
Patient, so it is metabolic acidosis, primary. Acidosis there that mix metabolic acidosis with respiratory acidosis. Mixed acidosis.
And what else?
Hypoxemia.
Yeah.
The isolated.
And ideally, if you had some more information, you should have commented on the anion gap, but we can't calculate the anion gap based on this ABG. Okay. And try and figure out, or this strong ion difference, and try and figure out what is the cause. But is this the kind of ABG you expect during CPR? Yes, no.
Yeah. Sometimes we'll get pH. Most of the cases we'll get pH of 6.8, 6. Less than 7.
pH will be there. Low bicarbs will be there. High lactates will be there most of the time.
But actually, when you look at a typical cardiac arrest, this thing, usually I think this is probably done because it's an ICU and the arrests were happening and you were resuscitating on site. It wasn't, that low a pH. But if you look at the traditional teaching or it's a typical MCQ which comes as, what's a MCQ, they'll give you an ABG which looks like this and they'll say, what does it fit in with? And you usually tend to see a metabolic acidosis with respiratory acidosis in a post-cardiac arrest. So this expected. Though I would have expected maybe the CO2 to be, what do you think about the CO2 here? So do you want to comment on how is the CO2 normal in a patient with pulmonary embolism?
It should be low, madam.
PC.
PCO2 washout will happen.
It should be low or generally
Hypocapnia.
Hyper means hypercapnia.
that is in which type of PE?
Intermediate, low and low risk PE, there will be hypocapnia.
You mean low
Hypocapnia.
CO2? Low CO2.
Yes, ma'am, because of
Yes.
washout.
Yeah. So then,
Yes.
are you surprised with this?
Did you give
Not
any
really.
random bicarbonate to this patient? In cardiac arrest, who went for 5 times cardiac arrest in 45 minutes? Empiric sodium bicarbonate to this patient? Presuming the pH will fall down. I'm just asking you, it's your case.
This case we haven't given, sir. Actually, if a pH is less than 7, we used to give, sir.
Okay. Because this is the only ABG that we are seeing. That's why I'm asking you.
Yeah.
Yes, sir.
So you said in a mild PE you can have a low CO2. In a severe massive PE, actually you can expect the CO2 to be normal or on the higher side. Why is that?
The ventilation perfect mismatch will be there now. Weak mismatch is there because of the carbon dioxide which is delivering to the alveoli and not getting alveoli which are getting aerated, those areas not perfused, man, because of that.
Okay. So there is dead space ventilation.
Dead space
Okay.
ventilation.
You should
What
mention the term
else?
again. Yeah.
Okay. Then what else? So you have a low cardiac output also, which also can result in poor respiratory muscle perfusion. Okay, so there's but here anyway you're assisting the ventilation, so that should not be an issue here. But essentially it's because of dead space ventilation and impaired CO2 clearance, which and what Dr. Saurabh said is very important because many a times bicarb is given in cardiac arrest. It's like even though it is mentioned in guidelines, you should not give. In this patient, maybe CKD would have thought maybe potassium is high, will give it off or something like that. And 5 cardiac arrests.
Right.
I'm quite certain if you go back to the chart, you'll probably see 1 bicarb somewhere there in the mix, which can also contribute to the CO2 being on the higher side. But that word should come out, no? Dead space ventilation. You mentioned ventilation perfusion mismatch, which is good, but dead space would have been better, especially since it's a massive PE. Okay. Go ahead.
So in ICU, we did point of care ultrasound. So it is showing that bilateral basal B line and lung sliding is present. That's suggestive no pneumothorax. And regarding heart, both RA and RV dilated, and interventricular septum is shifted to left side, and hypokinetic right ventricle free wall, and there is a hyperkinetic apex is there. So it is a history of some RV dysfunction is there, that it is it indicates right pulmonary artery after obstruction. It indicates a certain onset of right outflow tract obstruction, so history of pulmonary embolism. IVC is 2.1 centimeters, is less than 50% collapsible. So 4-point compression test is negative. It indicates no DVT in major vessels.
So why is the IVC less collapsible? What is the physiological basis for that?
So because in case of right heart failure, that back pressure transmitted to the IVC, so that leads to no variability with the respiration, and it will cause a decreased compression.
So there will be RV dysfunction, sir. Then there is shifting of septum towards the left ventricle. So in diastole, there is less filling of LV, sir. Preload will be less. Then this leads to decreased stroke volume for the patient. Also, there will be decreased
cardiac output.
Will be there.
Decreased perfusion of coronary arteries leads to.
I think sir is asking about why is the IVC? IVC.
I mean, you're going over the physiology, that is fine, but I was talking about the IVC.
So do you
Anyways, what you said
transmission
was fine.
RARV dilatation will be there because of high pressures.
transmitted
Due to outflow obstruction, because
That
of
is
those
fine.
pressures, there will be
What do you call this sign that you have found on the right ventricle? Hyperkinetic apex, which is this sign and
McConnell's.
Macon?
McConnell sign. Okay. So what
And
does the please go ahead, ma'am.
no, go ahead, finish.
No, it's okay, please.
So this, how important is this negative 4-point compression test?
To assist the, it is one of the risk factor to get pulmonary embolism, to rule out
DVT.
DVT.
So now you don't have it. So then
It may be you can see only less than 50% cases only have seen, ma'am. Only 40 to 50% cases only we have seen. More than 50%.
No, but in this patient who is on NORAD and you have typical heart findings, you actually need to do this at this moment of time. That's why this was asked.
yes, and see, you yourself answered and said 50% may have negative, and that's exactly the case. It is here you have a patient who's in obstructive shock, loud P2. There's no other reason. Okay, whether it's negative or positive, you're still going to decide what you're going to do. So, essentially, you need to know how to use the ultrasound in this situation. How can you use it? Okay, because it didn't stop you from thrombolizing, did it?
Yes.
No.
Just because it's negative. So it's like knowing when to do the test, and that is a usual problem which many clinicians who come through ICU complain, and they say that trainees know the different aspects of ultrasound, but when to use it? Should I use it? Should I do it? Okay, because that should not waste any time to initiating your treatment. Okay, so do we need? I mean, so you finished with this slide, or you've got some more?
We must ask regarding treatment. What
Okay, no. So how important or relevant is the D-dimer? Suppose a physician walks in and says, "Have you done a D-dimer?"
That will definitely happen for sure.
So D-dimer has negative predictive value, madam.
In which subset of patients?
Sorry, sir.
D-dimer has a negative predictive value in which subset of patients? When do you do D-dimer? What is the role of D-dimer in a pulmonary embolism algorithm?
When there is high clinical suspicion of PE.
In which type of patients?
Low risk.
In low risk, stable patients.
Low risk stable.
In this setting, it is absolutely not useful. Okay, the setting it's not useful at all. Somebody comes and tells you, "Did you get the D-dimer? Did you do the D-dimer?" It's absolutely not necessary. It's almost like your 4-point compression test, actually speaking, because it is useful in low risk
category.
Yeah. In a patient like this, even all the international guidelines recommend against doing D-dimer in high risk or unstable patients. You don't have to do it. It's not recommended at all. Okay. So what about CTPA? They want you to shift the patient for CTPA.
When patient has a patient hemodynamic unstable, ma'am. So patient 60 years, male patient having post-op day 3 sudden cardiac arrest. So patient, patient having loud P2 and RARV dilatation is there. Septum towards the left side is there. So it is suggestive of system PE only, that massive PE. Patient having SPC score of grade 3 to grade 4, and patient having RV dysfunction is there, very shock is there. So it is suggested towards the massive PE. So massive PE protocol is have to initiate the thrombolysis as early as possible now.
Yeah, so I think again here the ESC guidelines actually recommend that treatment should not be delayed for imaging in an unstable patient. That's just one line you just need to say. This patient has clinical features of an obstructive shock, fitting in with pulmonary embolism, clinically unstable.
Yes.
I will not shift this patient for a CTPA. Okay. Yeah. So when examiners look at trainees who are presenting, you're looking at the safety aspects. Okay. So are you going to be a safe intensivist? So those are few things which come out in terms of safety, whether you'll do anything. So it's good that you said that you will not do because of what patient being unstable. How do you define this massive PE?
It is based on 4 categories, ma'am. So according to European Society of Cardiology, so divided into high risk and intermediate risk and low risk, ma'am. So based on 4 parameters. One is SPC score of
Massive PE, massive PE. I'm asking for
SPC score of a grade 3 or grade 4 with RV dysfunction, with positive cardio biomarkers, with shock. So what was
tell me that again, just go slowly.
Cardiogenic shock, hypotension, and RV dysfunction, madam.
So cardiogenic, so either a patient who's had a cardiac arrest, okay?
Yes, ma'am.
Person who is hypotensing, or the person who has persistent hypotension requiring inotrosis, specific criteria about the blood pressure requirements. So systolic blood pressure less than 90 or persistent hypotension requiring inotropes. Okay. And that is how you define a massive or high risk pulmonary embolism. Okay. Does the definition require you to find out the amount of clot?
Shock itself indicates
high clot burden.
High clot burden.
So the definition does not depend on clot burden. Okay, it is mainly a clinical. So that's what we need to hear. So it's based on hemodynamics. PESI score, you mentioned PESI score.
Yes, ma'am.
When is PESI score used? Now people use the simplified PESI score, the SPECI, but then is it useful in this situation?
No.
And why did you mention it?
Useful.
So the SPECI is actually more for low risk pulmonary embolisms, for deciding whether the patient can be discharged or whether the patient has to stay in hospital for some time to get anticoagulation. Okay. So that is a simplified, it is not useful in our ICU situation at all. Okay. So please don't mention PESI for massive PE.
Just try to give to the point answers and try to be correct. Do not utter words which will lead to complications in the viva for you yourself.
Okay.
Yeah. You need to lead the examiner. Huh? Don't lead the examiner into paths which you may not be very sure about. Okay. Is there any change in protocol with ACLS in a patient with PE? So with regards to ACLS guidelines, in a patient with pulmonary embolism, is there any difference? You've written it there in your slide.
Thrombolysis and continuous CPR. Continuous CPR for
extra ECPR. Extracorporeal CPR is a new entity introduced.
Yeah, so I think for ECPR, yes, if you have the facility to do it, yes. But otherwise also it is prolonged CPR, which you're giving for 60 to 90 minutes, which actually most of the guidelines talk about, so that the effect of thrombolysis can be seen. You're not going to stop, you're not going to give, thrombolysis and then stop CPR of 20 minutes. So 60 to 90 minutes is the duration of CPR, which they recommend. Tenecteplase as a choice of thrombolytic. Is it all right? What the guidelines talk about? Means why did you choose tenecteplase? Alteplase is what comes in traditionally. I'm okay with tenecteplase, but I just want to understand why you chose it.
It's available in emergency department, that's why you use.
Sorry? It's available.
That's what they said.
I think it's also that it can be given as a bolus, no? Most of the studies I've looked at alteplase, generally you need to give it over 2 hours.
2 hours, yeah.
Tenecteplase is something which you can give it fast and quickly, and hence in a CPR situation, this probably would be an ideal and acceptable choice. In fact, actually some guidelines even for alteplase in CPR situations talk about giving alteplase as a bolus, but I've seen very limited literature on that. Okay.
Any role of biomarkers in this situation? Drop-I, NT-proBNP?
Yes, sir. But it is helpful in moderate, intermediate risk to low risk categories. In massive PE, shock itself indicate the do thrombolysis as early as possible, sir. It is helpful in intermediate risk to low risk people.
Yeah.
Intermediate risk only, ma'am.
Intermediate.
Intermediate.
Intermediate risk. Yes.
Particularly for the intermediate.
Yes,
Uh,
Because intermediate can be classified as a low risk and a high risk.
yes, ma'am.
Okay.
In high risk, it is positive. Without shock, it comes under high risk. Sir. Without shock, with or without cardiac biomarkers, comes under low risk PE. That actually 4 categories will be there, sir.
Yeah, it'll be a low risk. It's an intermediate low. It's intermediate high and high. So in the intermediate low and intermediate high, you look at RV dysfunction and biomarkers.
Biomarkers.
If only one is positive, it is intermediate low. If
Low
both are
risk.
positive, you go to intermediate high. That's all. Yeah.
Yes, sir.
And you should talk about eCPR and VA ECMO. You should be familiar with these terminologies if you're mentioning a prolonged CPR.
Yes, yes.
Yeah. You can go ahead, yeah.
So, with high suspicion for pulmonary embolism, that too, it comes under high risk PE. So we thrombolyze it with the training to place. So we control CPR for 45 minutes. So meanwhile, patient ROS achieved is maintaining with the triple vasopressors, and we did a repeat 2D echo after 30 minutes. So it is showing that there is improvement in RV and RV function, and there is a LV filling also improved. So vasopressor supports also slowly come down.
I think you have to move the slide, yeah. Okay.
This right ventricle, so free wall is hypokinetic.
So the right ventricle, so this is a hypokinetic RV free wall. This is hyperkinetic apex. The septum towards the paradox movement towards the left side. So significantly septum shifting to paradoxal movement towards the left side. So this is a dilated RV, and this is a paradox hypokinetic RV free wall. This is hyperkinetic apex. This is hyperkinetic apex.
Okay. I mean, ideally, it'd be good if we could have seen a proper 4-chamber where you can actually see the, both sides. That would have been ideal. Okay.
Yes.
Okay.
For us to comment on, all the changes that you mentioned in the previous slide. Okay. Is there any sign to kind of differentiate between an acute right heart failure versus a chronic right heart failure? Any numbers you know about?
60-60 sign.
And what is 60-60?
Pulmonary acceleration time will be less than 60 milliseconds, man. Then tricuspid regurgitation gradient will be less than 60 mmHg, man.
Sure. Okay. Good.
Significance acute.
Okay.
RV hypertrophy can also be there.
Hypertrophy in chronic, sir. In chronic, it will be there.
Go to the next slide.
So after thrombolysis, we started with a patient with unfractionated heparin. NV of creatinine is 1.8, as in the background of CKD patient. So patient had hematuria. We controlled bladder irrigation. We had transferred to PRBCs and FFPs and cryos. We temporarily withhold unfractionated heparin.
Any investigations that you did before transfusing PRBCs, FFPs, and cryos? Why did you decide to give all these threes?
Sorry, sir.
There is a drop in HB,
Any
sir.
investigations that you did before deciding to give packed red blood cells, FFPs, and cryoprecipitate in this patient?
Before it is hemoglobin of 11, sir. So
Okay.
after that patient having his HB of 7, sir. 6.9 actually.
How about the platelets?
Platelets are initially it is 1.8 lakhs there. So now it is
Why did you decide to give cryoprecipitate? Do you have a facility of TEG or ROTEM in your place?
Yes, it's there, sir,
It is-
but
Did you get it done in this case?
no,
No,
sir.
sir.
So what were the values of other coagulation parameters that you decided to give FFPs and cryoprecipitate? Or it was just arbitrary?
PTA.
PT
Like, how will you decide, whether you need to transfuse all these products?
Like with
How will-
PTINR and fibrinogen levels and all, we have to see.
How much should be there? Yeah. Any level?
PTINR? Are you talking about PTINR here?
No, like for effect, I mean,
What do you monitor when a patient is unfractionated? But otherwise also I'm just asking you broadly, what is your understanding? But when you're going to reverse anticoagulation, reverse the thrombolysis. So this is almost like you're kind of giving him.
You should definitely mention the values here. What prompted you to actually give all these products? How much you gave the products?
okay.
What was the change? Definitely requirement in this patient. This is a patient who actually have anticoagulated. It's not a normal post-op patient who has bled.
Yes, sir.
And you've anticoagulated him for a particular thing. And now you are reversing it.
Yes, sir.
So do you think your thrombolysis was a good decision?
Yes, sir. Yes, ma'am.
Because he survived? Now I'm just asking you, like, so what are the contraindications? Like, did you go through the contraindications for thrombolysis?
A patient having a recent hemorrhagic stroke.
No, in this situation, now there are list of contraindications. There's no time to go through all the list of contraindications. But in this patient, what was the contraindication? If
Hematuria,
there was.
related contraindication, hematuria and surgery.
Previous
Yeah, I think it's just the recent surgery.
Recent
Okay.
surgery.
Recent surgery is actually a relative contraindication. So it's all right to give, the risk outweighs the benefits outweigh the risk in this situation. And hence your decision on thrombolysis is perfectly correct. However, suppose the patient had a intracranial thing, then you'll have to think about other alternate options of dealing with the thromboembolism. In this situation, I think I would have probably also done the same thing, which is fine. But whether I would have reversed it, and I think that's what Dr. Saurabh is trying to say. Like, do you need to give so much of blood products in this situation, or which situation in a post thrombolysis and an anticoagulation way would you be so aggressive in giving all these products? In which kind of situation? You told me the shock improved and everything happened. Any criteria are there to kind of help guide you at the bedside? Okay, I need to reverse this urgently.
When APTT.
No, it's not based on APTT. So I think it's based on whether the patient has life-threatening bleeding. Okay, or
That gave a
patient has.
hint by mentioning intracranial bleed actually.
Sorry.
You gave a hint by mentioning intracranial bleeding.
Yeah. So whether the patient has life-threatening bleeding. Okay, so that is something where you are going to think about 100% going to reverse. The other thing is if the patient has any evidence of if there is bleeding into an anatomic site which cannot be corrected, compressed, or whatever the thing is. So like into the spine, into the brain, into the eye, into the pericardium, you need to reverse it because the patient will die otherwise. The third thing is also if the patient has got hemodynamic instability. So in addition to what Dr. Saurabh was saying about mentioning the coagulation parameters, also mentioned like if this was associated with a sudden drop in blood pressure, I can understand, okay, fine, we need to give all these products. But otherwise, it is not routine that you're just going to transfuse all these products because you're kind of in this situation for a hematuria alone. But if the hemodynamics worsen, it makes sense. So I'm just trying to help you understand that when you mention that you've done all this, if you don't have that information, you should say, I would like to know what these parameters were, or did the patient's hemodynamics worsen? Did the inotropes go up? Then it makes sense. Those are things which you need to, as an intensivist, decide. Okay.
Yes, okay.
All right.
Go ahead, yeah.
So sensor also improves, that is E4 VT&6, and repeat video showing that there is mild ARIA nerve dilatation and with a mild global hypoconnection with EF of 50%.
So
Soft
which vasopressors would you use in a patient with this kind of a shock, with right heart failure?
Noradrenaline.
You said triple supports, no? Which supports?
Noradrenaline, vasopressin, and ADR also given.
Adrenaline.
Okay, so do you know any of these which can actually decrease your right heart pressure? So both NORAD and vasopressin at lower doses, vasopressin at 1.8 units, less than that, 1.8 units per hour, can actually decrease your right heart pressures. Has some effect on decreasing. More than that, at higher doses, it can actually increase your afterload. Okay. So I know there's not a session on right heart failure, but in addition to, you must know the strategies you must employ to take care of the right heart. In addition to thrombolysis, it's not just thrombolysis, but you need to take care of the right heart in terms of the preload, the afterload, the heart rate, contractility, what all measures were done. I'm sure all that would have been done in this situation. Okay.
Of 24 hours of thrombolysis, patient having continued hemorrhage and melena, and HbF of 6.72, and platelets 1.3 lakhs, and INR is 1.13, APTT is 122, so apparent withdrawal temporarily. So patient having previously also Bowden creatinine was 1.8, it was increased to 4.5. So blood urea is 92. Potassium is 5 only, 5. So regarding LFTs, patient having mild transaminitis.
Have you heard of PERT?
Pulmonary embolism risk criteria.
No. So this is actually a terminology which is there from
Rule out
2012.
criteria. Sorry, rule out criteria.
No, not PERC. I'm not talking about PERC, but I'm talking about PERT. PERT. Okay. So these are the pulmonary embolism response teams, which actually is a multidisciplinary team, which actually all centers, big centers should have. You have a pulmonologist, you have an intensivist, you have an interventional radiologist, you have a surgeon, cardiologist, all part of that team to kind of decide whether other options need to be done. In this situation, it's very clear. But suppose thrombolysis was not possible, what are the other alternative options for dealing with pulmonary embolism?
Mechanical
Other than
thrombectomy will be there, man. Then catheter guided extraction of clots will be there. Then ultrasound, this thing next.
Okay, so you're talking about catheter-based therapies, which can include thrombolysis, local thrombolysis, or it can include clot retrieval. Yeah. Okay, so those but these kind of therapies, suppose this was a patient with an IC bleed and who had this, which we had recently in CMC. We had a patient with traumatic brain injury who had this. The patient had to be put on BE ECMO and then taken for a procedure. Okay, so in that situation, you have ECMO is the priority. You're going to put that and do the procedure and take for a catheter-based clot retrieval. That was what was done for that patient. So you must know the alternate therapies that can be considered if thrombolysis is not an option in a patient with pulmonary embolism. And PERT is a nomenclature which is something which can be incorporated in your answers as well, in your theory answers as well. Okay. All right.
The patient was extubated after 48 hours. So AK also improved. Patient discharged with apixaban, 15 mg for 21 days, followed by 20 mg for 3 to 6 months.
When do you use IVC filters in a pulmonary embolism case? Any role of IVC filters?
IVC filters.
Any role in this patient or when it is used?
If there is a contraindication for thrombolysis and there persistent DVT also present, then we can keep IVC.
Contraindication for anticoagulation, not thrombolysis.
Bleeding.
For anticoagulation. For thrombolysis alternatives, you already told about catheter-directed therapies.
Yes.
Yes.
Yeah. For anticoagulation thrombosis or recurrent venous thromboembolisms, think about putting a IVC filter. And why did you choose apixaban in this patient?
So there is no monitoring by.
What
There
is
is
the
no
class of agent that apixaban belongs to?
TENA inhibitor, like TENA inhibitor.
Okay.
NOVAC.
Newer oral anticoagulations, TENA inhibitors.
TENA inhibitors.
So why did you choose this amongst them? Was the creatinine absolutely normal in this patient?
Sir?
You said AKI improved. Was the creatinine absolutely normal?
So it came to 1.8 baseline only, sir. Before it is 5, sir. After it is at the time of discharge, patient having creatinine of 1.6, sir.
So you should know the metabolism of all the NOACs also. Okay.
And how to reverse it, how to identify whether the effect is a lot. I mean, that again will be beyond the scope of this. We've already reached 8 o'clock. But those are things which you need to know. Newer oral anticoagulants. How does it work? As Sir said, the pharmacodynamics, pharmacokinetics, metabolisms, reversal agents.
See, idea is whatever you're mentioning in your slide, you should be very clear about all these things. Like from the first slide, you started mentioning MMRC, the score. You should be very clear why it is used, in which patients it is used.
Okay.
Yeah, throughout whatever you mention, whatever you present in the case, you should be very clear about all these things.
Okay.
No terminology should be presented in which you should be having any doubts.
Okay. I think Dr. Ravi Shankar, we've reached 8 o'clock.
Yeah, I think
You want us to continue? We can.
Yeah.
I think we'll give them a break.
Yeah, only couple of things I think which were missed. I think one question was, is there any role of, half dose thrombolysis, which is still being practiced at some centers? So, Sai Kishan and Shiva, any, thoughts on that?
Patient who are at high risk
At least in this kind of patient, at least I think we should be giving a full dose thrombolysis. I don't think a patient who's hemodynamically stable has all the signs on echocardiography in which you are suspecting of obstructive shock. He's on a decent level of NORAD support, and he's having all kinds of symptoms that he'll probably not make it. He's having repeated cardiac arrest. And I don't think we should even think about any half dose or half measures in this patient.
Yeah, I agree completely. I think that would be something which is being researched right now. Again, this trials, you should know, there's the PERT-3 trial, which will be coming out next year or year after next, which is actually looking at the role of half-dose thrombolysis in intermediate high-risk patients. In that patients versus catheter-based therapies. So that is the study which is being done. And I think the PETO original trial actually looked at low dose, half dose alteplase versus placebo. And even though there was a hemodynamic benefit, there was more bleeding. But in this situation where you have a patient with massive pulmonary embolism, there's no question about it. You are going to give full dose and nothing else. If there is no, in this kind of a situation where there is no absolute contraindication to thrombolysing.
I think that's it from my side, madam. Anything from your side?
Any other questions in the chat box? No questions?
Yeah, there are 3 questions, sir. One is, I think one was question regarding the ABG, and the other question was low dose adrenaline also help increase RV function. The third question is economically challenged situation, can ST streptokinase may be used?
We use it. Even though the recommendations in CMC, like we do have a lot of patients where who cannot afford alteplase or tenecteplase, and so we do use streptokinase as an infusion over 24 hours, and we give it. Yes, it is being used, but we all know that the complications, the more generalized bleeding risk that can happen. So those are things which we need to explain to the family before giving it. I don't think you will see an evidence-based guideline for that.
Yeah, because I mean, evidence is tilting, but still circumstance, depending on the situation, definitely we have to choose depending on the
It is
situation.
definitely better than not giving anything. So that is why we
Yes.
chose it. And there's a question if first ABG can be a venous sample. Definitely in case of cardiac arrest, we obviously take a blood gas sample. We do not know whether it's a venous or arterial, what kind of blood gas sample. We just want to find out clues why the patient has gone into cardiac arrest, what are the correctable factors. Unfortunately, he has an arterial line in situ. It's almost a blind prick.
Yeah.
No,
Read from
blind prick
blind
only, sir. No arterial line in situ because a patient is
There's no
in.
venous or arterial line, it's a blind prick. So
Yes.
there's no option.
So actually each of these things like ABG or the not ABG, we can call it a blood gas, it can go into different levels of discussion. You
Yeah,
may not reach pulmonary embolism at all in your discussion. You may be stopped along the way, and that is what happens in a lot of critical care discussions actually. Here I've kept it focused because the topic is pulmonary embolism. We don't discuss it. I think Dr. Ravi Shankar won't be happy.
No, no, madam. I think we are focused discussion purely concentrating on pulmonary embolism. I think, like you rightly said, I mean, not only just about thrombolysis, people should also know how to manage an acute RV dysfunction in these settings. Actually, that
Yes,
becomes more important.
that's very, very important. And that is something which you will be asked definitely. How will you take care of the RV preload, RV afterload, the heart rate, the contractility? What are the different things you'll keep in mind? It's like you should know that. Anyways, I think we don't have time to discuss that.
I think this is one of the important case. If it comes as a main case in your exam, I think you're privileged or lucky because it is straightforward and it's easy to score.
very straightforward, to be honest.
Yes. I think both Saikishan and Shiva, you've done very well actually. I think Madam and Saurabh sir has actually tried to give you the most important or the critical points what are very relevant for the exam actually, including the current evidences, what are the practice changes incorporating how the AHA recommends a prolonged CPR and the role of PERT teams, all these things. I think they have clearly highlighted. If there are no other questions, madam, can we conclude the session?
Yes, Dr. Ravi. Thank you so much.
Thank you. Thank
Well
you.
done, well done, Dr. Sai and Dr. Shiva.
Thank you.
It's not easy to be answering questions live. Well done.
Thank you.
Keep working
Thank you,
hard,
thank
keep
you.
studying.
Thank you, Benila madam, for joining us, and thank you, Saurabh sir, for joining us and contributing to the masterclass. Every time when we needed help, you're always there, and you kept on supporting us. Thank you. Thank you so much. Thank you, sir.
Thank you.
Thank you
Thank
so
you.
much for
Thank
inviting
you.
us.
Thank you. Thank you,
Dr.
everyone.
Sai.
Thank you.
Pleasure.
Bye. Good night.
Pleasure to be here. Bye bye.